Namaskar, everyone. A warm welcome to all our participants joining us today for this important and extremely practical session on how to approach a patient in the emergency room. The emergency room is often the first point of contact, the most pressured environment, and the place where clinical judgment, communication, and prioritization intersect in real time. Today's discussion is aimed at strengthening that very foundation. Let me begin with a scene many of us here will instantly recognize. It's 2:30 a.m. The ER doors swing open, a patient is rushed in, no complete history, anxious family members, limited time, and 100 decisions waiting to be made. In the moment, everything depends on the first approach, not just what we do, but how we think, how we prioritize, and how we lead the room. That is exactly what today's session is about. I am Dr. Vandana Chawla and I'll be moderating today's webinar on how to approach a patient in the emergency room. Introducing the keynote speaker. Before the protocols, before checklist, emergency care begins with systems that work when time is slipping away. It is my privilege to begin by introducing our keynote speaker, Dr. Shuchin Bajaj. Dr. Bajaj has spent building exactly those systems. As the founder director of Ujala Cygnus Healthcare, Dr. Bajaj has developed and scaled multi-speciality hospitals across Tier 2 and Tier 3 city regions, where access to timely emergency care often decides outcomes long before a patient reaches to a metro hospital. Across these geographies, one principle has remained central: delivering the right care in the golden hour. Dr. Bajaj brings a rare perspective, where clinical urgency meets system design and where emergency response is not an exception but a daily reality. In his keynote, he will take us through the mindset and foundational approach to handling ER patients, especially in real world, resource variable settings. Candon, could you please connect?
कैलन आवाज नहीं आ रही है, एक बार देख लो सर.
Sound is not there, Candon.
Sound is not there, yeah.
Hello, Namaskar, warm greetings, and thank you very much for joining this important webinar. And a deep thanks to Dr. Vandana Chawla for organizing this wonderful webinar, and Dr. Harmeet Singh for sharing his vast knowledge on this subject with all of us. These webinars and continuing medical education programs are very important for upskilling for all of us and making sure that we are aware of what exactly we need to do. Today's topic is, as I said, very important. When we talk about emergency care, we often think of protocols, algorithms, monitors, and rapid decisions, of course. All of that is essential, but before anything else, before investigations, before documentation, even before diagnosis, we need to understand that there is a human being in distress and a clinician who becomes their anchor. An emergency is not just a medical event. It is fear, it is uncertainty, it is loss of control for the patient and often for the family that is standing outside, not really knowing what is going on in the ER room, because reflexly our security guard will come and say, बाहर खड़े हुइए आप, अभी डॉक्टर साहब इलाज कर रहे हैं, बहुत सीरियस है. So it is a very traumatic time and a very uncertain time for everyone involved. How we approach a patient in those first few minutes can change outcomes, not just clinical outcomes but emotional and ethical ones as well. In emergency medicine, time matters, but so does presence. The most important skill, according to me, in emergency care is not speed alone. It is structured calm. If we are calm about things, if we are seen to be calm, it gives out positive energy to each and every person present there, including the relatives, the families, and the patient. When a patient arrives, chaos often arrives with them. Right? Multiple voices, alarms, anxious relatives, incomplete information, everybody is screaming. Your first role is to bring order to this disorder. That is why we are emphasizing this systematic approach. Whether you are a junior resident, a nurse, or a senior consultant, the fundamentals will remain the same, right? We all know them: airway, breathing, circulation, disability, exposure. Not because it's theoretical, but because under stress, structure protects us from errors. Protocols are not a substitute for thinking. They are a safety net when thinking is under pressure. I'm sure you've all seen that movie Sully, the pilot who landed the plane on the Hudson River. He says he did it because he had a structure to follow. He had a list which he kept ticking on and simply followed that list and landed the plane comfortably when everything was chaotic. But let me say this clearly, structures are important, but a patient is not ABCD. They are a person whose worst day has just become worse than they could ever have thought. So while your hands are working, your words matter a lot. Simple sentences. I am here. We are taking care of you. You are not alone. चिंता करो अभी डॉक्टर साहब हैं हॉस्पिटल में हो. These simple things can reduce panic, improve cooperation and even stabilize physiology. I have seen that happening. Please trust me. Emergency care is one of the few places in medicine where communication is the treatment. Another key principle which I feel is, sorry, there was a call coming. Another key principle which I feel is important is treat first what kills first. Do not chase perfection when survival is at stake. In emergencies, good and timely is definitely better than perfect but late. My Stanford professor used to teach us day in day out, good is very important to do, and best is the enemy of good sometimes. So don't keep waiting for the best things. Just do the good things timely. Do not chase perfection when survival is at stake. In emergency medicine, as I said, stabilization always comes before diagnosis. Reassessments are as important as first assessments, and humility is very vital because emergencies keep evolving minute by minute. Equally important is team behavior. No one manages an emergency alone. So clear roles we should have, closed loop communication and respect across hierarchies. Patient may not remember your diagnosis, but they will definitely remember whether the team looked confident, coordinated and compassionate. And finally, I want to speak about mindset. Approaching an emergency patient requires clinical sharpness, emotional regulation and moral clarity. We must care deeply, but we must not panic. Act decisively, but not arrogantly. And remember that every emergency patient deserves the same dignity, whether they arrive in an ambulance or walk in quietly, whether they come with 20 relatives or whether they come alone. Emergency medicine actually reminds us of why we chose healthcare in the first place, because in these moments when life is fragile and trust is instant, this is how we approach the patient is the first intervention that we do. So I really hope today's session strengthens not just your skills but your confidence and clarity in these key moments. Thank you very much for the work you do every day for all our patients, often unseen, often unacknowledged, but absolutely vital. So let us begin the session, and I really have high hopes on Dr. Harmeet and Dr. Vandana Chawla. I am sure it will be a brilliant session and I am eagerly waiting to learn as much as you all are. Thank you very much.
Thank you, Dr. Bajaj, for that insightful and grounding keynote. You've beautifully set the stage by highlighting why the initial approach in the ER matters, not just clinically, but ethically and systemically. What you all have just heard is the why. Why the ER approach matters, why the first few minutes define outcomes, and why systems training and leadership must align when seconds count. Building on that foundation, now we move on to the how, the clinical and operational core of today's session. Every ER clinician remembers their early days, multiple patients, simultaneous priorities, and the constant question, where do I begin? Our next speaker, Dr. Harmeet Singh, has spent years answering that question on the floor again and again. Dr. Harmeet is known for translating emergency medicine principles into clear, structured, and practical approaches that work even in the most high-pressure environments. Today, he will walk us through how to approach a patient in the ER step by step, from first look to triage to decision-making, communication, and avoiding common pitfalls. Dr. Harmeet, the stage is yours.
Thank you, Dr. Vandana, and special thanks to Dr. Bajaj, who has given, very concrete and very concise message to the audience that how actually an emergency physician should be, emergency team should be, and what are the expectations from the patients when they come to the emergency room. Thank you, Dr. Bajaj. So let's begin without wasting the time that today's topic is very common. It is not unique. It is very common actually. Every day we do this, every moment we do this, every second we do this. Being an emergency physician, being an emergency team member, and everyone does it every day. So how to approach a patient in emergency department? It is, everyone may think that why this topic was chosen. So next, Kelvin. So why this topic was chosen? Because, if I ask this question to the audience, so what do you think? If you are interactive, I will welcome to be interactive, and let's have an interactive session. Anyone can answer it. Whenever I have a question, whenever I ask something, you can raise your hands, or you can unmute yourself and you can answer. So why this simple topic, how to approach a patient in emergency room? So I will just begin with the approach of emergency physician and the approach of other physician, medicine physician or other physician is totally different. The way of thinking is different. We think differently, and it's not. The goal is same, the patient outcome, to treat the patient on time, but the thinking and the approach is different. There is a if we see, for example, I will have a patient and there is a case, how an emergency physician approach to that patient and what the other physician can think about it. When it comes to the differential diagnosis, provisional diagnosis, or the diagnosis, or the critical actions. Actually, our job, emergency physician job, as rightly said by Dr. Bajaj, is not to come to the diagnosis, but our job is to at least recognize the critical actions, criticality of the patient, and act on these critical actions. So why this class? There is some research I have done, and I found that our incidents that happen in the emergency department are, for example, 1 in 8 ED patients receive an incorrect diagnosis. 1 in 50 patients have adverse event rates, and mortality rate is also high if we don't have a right approach, right treatment, and on time treatment, because time is life in emergency department. Serious harms are there if we miss the diagnosis, miss the critical action, and these all can lead to the fatal condition to the patient. Even patient may die if we don't act on the same time, on the right time. So the prevalence of having the misdiagnosis related harms in the emergency room that can happen are almost 89%. It's a huge number. Why it is? It's not intentional, it is unintentional. When the flow of the patient is very high in the emergency room, one doctor or two doctors are on duty and they have to attend all the patients, and it can happen if we don't have the structured emergency department. Delayed treatments can happen up to 86%. So patient coming to you, no, back, Kalden, back. So patient coming to you, there is a delay in treatment, for example, because of the disturbance of the other patient. There we have a green patient, he's making the chaos, he's doing a lot of things, and our intention, our attraction is towards that patient, and we, in that case, we will ignore or unintentionally we will delay the treatment to the actual red patient. So impact on mortality is very high, it's 9 to 10%, and also demographically, women and people of color are 20 to 30% more likely to be misdiagnosed. It's a global data, not about the India only. So delayed infection diagnosis more than 10%. So that all this, if we summarize all these things, all these incidences and these blunders, the structured emergency and a proper accurate approach to a patient in emergency room becomes very, very important. What actually is triaging? What is triage? So every emergency department works. It's a basic thing in emergency department which is called as triaging. So what actually is triaging? It is must mandatory to have the triaging in emergency room. Why it is important? I will tell you why it is important. So triage is a systematic process of prioritizing patient in the emergency department based on severity of illness or injury rather than an order. So once a patient comes to you, we have seen, as rightly said by Dr. Bajaj, we have a crowd of patients. We have 10 patients together. We have 20 patients, sometimes disasters. Sometimes, a lot of patients coming to you and everyone wants you be there on the bedside. So what actually and how you are only the one doctor in the emergency or two doctors dealing with 10, 20 patients, and this is the actual real thing that happens in emergency department. That's why I always tell emergency physician is a hero, and he's half administrator and half clinician, that he has to find out everything, and he has to satisfy the patient outcome. He has to satisfy the patients and their attendant. He has to attend the one patient is having the 10 family members, so he has to calm everyone by making them calm or interacting, having a good communication without any gap. Next, so the key objectives of triaging are identify life-threatening conditions early. This recognition, I told the word recognition by emergency physician, to categorize, to recognize the patient, which patient he needs to be focused and which patient he can delay sometimes. Ensure optimal utilization of ED resources, and triaging reduces waiting time for critically ill patients, improves patient outcome and safety, and also maintains efficient patient flow during peak loads and disasters, as we discussed in previous slide also. Next, so who performs the triaging in emergency room, emergency department? Usually it should be done by the emergency physician or by an emergency nurse. So any of one can do it, and if nurse is doing, I would recommend that it should be supervised by the emergency physician. And it is done basically on the basis of vital signs, chief complaints, and the clinical judgments, depending upon the on-site triaging, whenever a doctor or nurse is doing the triaging. So triage assessment. So we have the triaging. There are a lot of triaging systems. We have a Australian, we have a AIMS, we have ESI categories of triaging. Every department, every hospital has it. Is depends upon which category they use. It's not necessary that they use only one AIMS or other. It depends upon the institute to institute. So red, if a patient is labeled as red, the person doing the triaging or having the assistant should take this patient himself or herself to the zone, red zone. If you see the yellow zone, patients also should be accompanied by the doctor or the nurse who is doing the triaging, or if they have the person there today, because they should not be sent alone to the to the department. Usually triaging is an area which should be in the emergency department, and then from the I will tell you how actually the structure of emergency should be. And then there's a green is the category of the triaging, which is low risk patients and non-urgent patients, and can be sent alone to the emergency department. And even you can do the fast tracking and save the time on these for the patients who are actually critical in the red or in the yellow zone. So triage. So red is immediate and includes the life-threatening conditions like cardiac arrest, severe trauma, shock, airway compromisation. These are the cases whenever it comes to the emergency department in the triaging zone. These should be labeled as red and should be sent to the right area, right zone, which is called a red zone. Then yellow is urgent and serious but not immediate life-threatening. For example, chest pain, fracture, moderate head injuries. And the green, as I said, non-urgent, minor injuries or stable conditions. Example, minor cuts, fever without danger signs. So these patients can be sent to the fast track zone or the green zone. Then we have the black, usually 1 or 2 beds for the dead bodies or brought dead patients. And what actually is the message of what actually is the moral of having the triage is right patient, right care on right time. This line is very, very important. Right patient, right care, and right time. So this is very important slide. Time is life in emergency. Everything is time bonded in emergency department. If we ignore a patient for 5 minutes, we can lose the patient. If we ignore a patient unintentionally for 10 minutes, we can lose, because time is brain, time is muscle, and time is life. So in the emergency department, whosoever are the emergency heads, emergency team, they should remember. So these are the important points that has to be in the emergency department, bonded to the time. Door to the triaging, when did the patient come to the this hospital in the door, and in which time, in how much time the triaging was done. There should be a time in this. Triaging to the bed, after triaging, how much time it takes to the taking the patient to the red zone, yellow zone, or green zone, because we should not waste the time in the triage. If a patient is having acute MI, we should not waste the time in the triaging, so that patient can collapse in the triaging only. So go to doctor. If the patient is now in the right zone, the doctor, in what time doctor has done the initial assessment, doctor has approached to this patient, doctor go to nurse, when did nurse attend this patient, and after seeing the patient, when the order was given for the treatment, for the medicine, and in what time. These are very basic and important things where we can lose a patient, as well as we can have a medical legal litigations. Whenever there is a litigation, there is a case in the court, these are the small things that has seen by with time by the court. Admission time to ICU shift, when was the admission advised, and when did the patient was shipped to the ICU on the right place. Door to needle and door to balloon is very common, and we all know about it. Now now patient has done the triaging and the patient is on the right zone. Now how did we approach, how should we approach a patient being an emergency physician? So before approaching, these are the very important points that is very important to know by the doctor or the nurse. Why? I will tell you. So mode of arrival, while the patient is walking stretcher or wheelchair. Usually the patient on polytrauma and patient in septic shock, they come in the ambulance, they come on the stretcher. So there only you can see the seriousness of the patient, how sick or serious is the patient. Time of arrival is important. Time of arrival is important for treatment and legal perspective. And brought by also, the patient was brought by the EMS, was brought by the family, by bystander, because these all points are related to the criticality of the patient, how seriousness of sickness of the patient can be. You have to assume if a patient is brought by the bystander, maybe how long the patient was on the roadside. That increases the criticality of the patient. And then we do the triaging and to the right zone. Next. So whenever patient comes to you, you are sitting or you are standing in the emergency in the zone or in the reception. So always while walking the patient to you, while bringing someone is bringing the patient towards you, always ask this question to you: how does patient look like? Is patient stable? Is patient unstable? Is patient looking drowsy? Is patient looking altered mental sensorium or alert? Is patient is having blood all over the face or vomiting blood, anxious, agitated, pale, severe shortness of breath. So these are the things that you assess even while patient is walking to you. You have not touched, you have not started your approach, but you assess these points, which can give you click. I have to rush to this patient immediately. So whenever you approach to the patient, first thing that you should do, introduce yourself. I am doctor this and this, and I am your attending physician, or I am consultant, whatever you is your position. You can tell to the patient, and if anyone is with the patient, you can introduce yourself to that attendant also, and ask the name of the patient. Ask him to introduce himself also. This will give you a lots of information when you are asking patients to talk. If a patient is talking to you talking to you in full sentences, you can see the airway is patent. If the patient is not able to talk in full sentences, then you assess the patient is not in full sentences, so the airway is compromising, and you start there only. Your action starts there only. After introduction, you go to the patient. You are on the bedside. You start the ABCDE assessment, which is called primary survey. So airway, how to assess the airway. I just told that you have to ask the patient to talk in full sentence. Maybe he's not able to. He's very dyspneic, or he has a lot of blood or dirt in the oral cavity. So you need the suctioning, you need oxygen, or even you need the intubations. Then you check the breathing part, which is also very important. Breathing part, and here you check how is the chest. Is the patient having chest rise, normal chest rise? Is it symmetric? Is it asymmetric? Or is patient cyanosis or not? So this gives you you have to rule out the life-threatening conditions like pneumothorax, hemothorax, tension pneumothorax. even pulmonary embolisms, these kind of life-threatening diseases, illnesses, you rule out here only in the primary survey. Then comes to the circulation C part, where you see what are the vital signs. Are the vitals stable, unstable, above the normal range, below the normal range, and is the patient bleeding? Then you control the bleeding also there only. And if the patient, if you're not able to do the vital, then you check the CRT, which should be less than 3 seconds. So these are the very important critical points that a doctor has to check whenever he's doing the primary survey. And believe me, it won't take much time. It takes only 1 or 2 minutes, not more than that. Then disability, here you do the quick neurological survey, like you check the people, you check the GCS, and here you can check also if the patient is alternative sensorium unconscious, you check the blood sugar level. And then there is exposure. Then you expose the patient. If the patient is is of trauma case, you expose the patient, check his extremities, check his pulses, peripheral pulses. Are they feeble? Are they normal, irregular? So these are the quick primary survey which rules out the life-threatening things in a patient. Then depending upon the airway, breathing, circulation, you do there and only there you do the action. Action can be in the form of IV access, quick IV access. You ask your nurse to quickly do the IV access to large bowel cannula. If a patient is in red zone, yellow zone, you should always put the 2 large bowel cannulas, and there only you can take the samples also, and either you send there only if you are confident, or you can hold, but take the sample. It prevents the giving the again and again multiple pricks to the patient. If oxygen is required, you start the oxygen. If intubation is required, you start doing the airway management, or put the patient on cardiac monitor, and then other required orders you can give there only, which are required depending upon the patient condition and the situation. So after that, after completion of the airway quick primary survey, then you now you have seen the life-threatening conditions. You are sure now, confident that you have done. Patient is now a little safe. You have completed or act very quickly to save the patient. Then only you take a history of present illness. You take the short history of the patient. What happened to the patient, when it happened. For example, if a patient is having a vomiting, how many episodes of vomiting with the characteristic, and then how was the vomiting patient. If a patient is having chest pain, when did chest pain started, and you also check how is the pain score. So a lot of things, you small short history you take there, and it should be followed by sample history, SAMPLE, sample history. So mnemonic is SAMPLE, so that we should not miss anything. So S means symptoms, or you check there what are the symptoms, and duration of the symptoms, characteristic of the symptoms. Then you check their allergy quick, because you have to give some medication, so you ask about the allergy or not. Is the patient allergic to any medication or not? Then you check what are the medications the patient is already taking, or he has already taken. For example, patient of diabetes is taking medicine for the diabetes, or antipsychotic for the patient with having the psychological issues. So depending upon the patient, then you ask about the past medical history. What are the medical history? Can be diabetes, hypertension, CAD, CKD, whatever the history of the patient, and depending upon that condition, which medicine patient is taking. Then L means last meal. When did the patient has taken the last meal? It is very important for knowing if you need quick surgeries, quick airways, quick suction, so that the patient won't vomit, or the patient don't have the aspirations. In the female, you also ask the LMP, last menstrual period, when was it? Because if the patient is having female patient having lower abdominal pain with bleeding, PV, maybe having ectopic pregnancy, so rule out here also. And other event, what were the event last 24 hours, 12 hours, or 10 hours? You ask all these, and collect all this information, very quick, concise information which is required that moment for the patient benefit. Then after that, you always reassess the patient again, A, B, C, D, E, and keep assessing the patient, ABC. Whatever action you have taken, reassess after the action. It's not that you have done the intubation and you know that now airway is okay. No, reassess again. How is the saturation? How is the air entry is present or not? Again and again. So after every action, please reassess the patient. What is the outcome of your action? So here you send some labs which are required, basics or any metabolics. And if a cardiac patient, you can send the cardiac enzymes and other. Every hospital emergency department is having the protocol and the clinical pathways. and about the patient, different condition of the patient, and accordingly they send the basics or the required important lab diagnostics. Any treatment orders, if you want to add on there, you can add on here also. So after doing the triaging, after doing the primary survey, after doing the history of present illness, after doing the sample history, and after acting by your actions, starting the treatment, sending the samples, or doing the life-saving things you have done, you then only come to the secondary survey. Okay, and what is secondary survey? A secondary survey is always after the primary survey, and it should start from head to toe examination actually. So it starts with the head. So head, mnemonic is HEENT, HEENT, HEENT. So head is the head traumatic, head traumatic, you check it. Then ear is any secretion from the ear, is any blood from the ear, and depending upon the situation, maybe in head injuries. And eyes, how are the eyes? Is any redness of eyes, any watering of eyes, anything. Then nose, you check the nose, both the noses and throat. How is the throat? And then you come to the neck. How are the veins in the neck? Is there any crepitation? You palpitate the neck, both sides. You check the trachea. In pneumothorax, the trachea may be diverted to the opposite side. So a lot of information you can collect by doing this quick secondary survey, head to the which is called HEENT. From head to the neck. Then we continue the secondary survey. Then comes to the from the below neck is the systemic examination. Chest, in chest we check both the cardiovascular as well as respiratory system. So we check is the air entry both sides normal. We do the percussion, palpation, and also palpitation, and we check, we expose the patient actually in this secondary survey, and we do these examinations. Then we check the heart, sounds of the heart, any regularity or any additional sounds in the heart, in the cardiovascular system. So in this we can get a lot of information, like patient is in the pneumothorax, you will see that there is absence of the or decreased air entry on the right or either side of the chest. So you can at least get some information there and only. And in tension pneumothorax we have to act there only there. So we can do the needle decompression or ICDs and all that. Then comes to the to abdomen, we do the abdominal examination. Actually I recommend every emergency physician to do this thorough examination to each patient, but focus the symptoms. For example, the patient comes to you with the abdominal pain, you do all the examinations and focus on the abdomen. Detailed examination should be taken of that area where the patient is having more symptoms. But you should not ignore, you should not avoid the examination of other parts of the body also, because that is the main approach, mandatory approach in emergency department. Then perineum area, back, neurological exam, PR if required. And here you also see the extremities. You see the extremities are warm, cold. It will give you the signs of the shock. How are the pulses? Is sweating, diaphoresis patient, which can lead, you can think about the any septic shock, any or cardiogenic shock. How is the pulse? Regular, irregular, feeble, tachycardic, bradycardic. So here a lot of information you get on this examination only. Then action and reports. After doing the secondary survey, you go back to the and reassess the patient, and is the patient same, is patient improved, or is patient deteriorating? Okay. If patient is deteriorating, you have to reassess the patient and do some actions. If patient is same, then you have to think how to improve the patient. Then after taking the primary survey, secondary survey, after sending the required information, orders like labs, EKGs, or imagings, then you think about the differential diagnosis. You have already thought about it. Then you make the provisional diagnosis based on all the collective information, and then later the final diagnosis. As I said, if you have the final diagnosis, it's good, but it's not mandatory to have the final diagnosis in emergency, but only the criticality and the critical actions has to be taken in the emergency department. We cannot miss the critical actions in the emergency department. As Dr. Bajaj also told that stabilize the patient in emergency is important, more important than the final diagnosis. Comes to the disposal of the patient, and before disposal, you want to admit this patient to concern or required specialty, like maybe in ICU, maybe in under neurology, maybe under gastroenterology, depending upon what kind of patient you have received. And you take the consultation, you talk to the consultant, you discuss the case with the consultant, and you tell him that this patient was, from the beginning. Actually, the telephonic calls, or the doctor is present there, he will see there. If doctor is not there, then telephonically you have to in detail you have to discuss the patient with the your senior, your consultant, so that jointly, if anything is missed, he can recommend you anything, or then you admit the patient under him. So at the end, then comes the disposal. After referral and everything, if your doctor consultant has said yes, you can admit my patient, or you can discharge, or whatever. The patient is not ready to admit, you can send the LAMA, or you can refer the patient to the higher center if you don't have the resources. So depending upon the all these informations, do you take the decision of admission or LAMA or discharge or refer to the higher center. So this was the approach. This should be our approach in a patient coming to the emergency department, and this approach is very, very mandatory. And I request all the emergency physician, emergency team, please do not ignore even a single point given in the in presentation. Almost every department is having their initial assessment paper or form. They include all these points, and you should not miss, because every point is comes with a lot of informations which can help you to treat the patient in the emergency on right time, right place, and admit on the right under doctor right specialty. So there is a case. Let's have a discussion on the case. Case is, the patient came to you, 19 years old male, complaining of chest pain, and vital signs are BP is 115/65, respiratory rate, heart rate is 100, RR is 18, then temperature is 37, saturation is 99 on room air. So the first point that comes to is the triaging, and how does the patient look like? Okay, how does the patient look like, and how does you feel when you enter the room? How is patient? You assess. The first question that should come in your mind is, how does the patient look like? Is patient here? The patient is uncomfortable, anxious, but alert. So what do you think? Why patient is uncomfortable, having the chest pain, anxious, but alert? So here again, you have assessed. You have even bringing the patient towards you, or going towards the patient, you have assessed important. You have collected the information, important information from the only by physically looking on the patient. So after that, we do the primary survey. In the primary survey, in this patient, the patient is speaking in full sentence. That means airway is patent. Breathing, no respiratory distress. That means the breathing is also normal. And then circulation. In circulation, you see the skin is diaphoretic. Patient is sweating. Pulses are full in peripheral extremities. Pulses are okay, but patient is diaphoretic. So diaphoretic can be a lot of factors. Maybe hypoglycemia, maybe shock, drug overdose. Anything can be information about the skin diaphoretic. Then GCS, you check the GCS, RBS, people in this patient are normal. So next is action. So in the primary survey, the action is oxygen via nasal cannula, or for the support, or by non-rebuttal mask, 2 large IV bore cannula. Then monitor, you have put the cardiac monitor, and you have started the 1 liter normal saline bolus. And you have sent the labs like CBC, basic metabolic profile, cardiac enzyme, because patient is chest pain. The doctor has sent the cardiac enzymes, D-dimer, coagulation studies, blood type, and then you took the samples and hold it. Then patient is chest pain, EKG is mandatory, and chest X-ray. In the history of present illness, it is a 19 years old male with a history of psychiatric disease, including depression and anxiety, presents with sudden onset of burning chest pain. Sudden onset of burning chest pain. I have highlighted the important points which can direct you towards the the criticality of the patient and the diagnosis of the patient. While at rest this morning, you have to check the detailed history. How did the burning chest pain started? What was the reason, factors behind it? The pain is rated 10 out of 10. So high pain score is 10 out of 10. Diffuse, radiating to the shoulders and back. So here, what do you think? What is the condition? Anyone can tell me? What are your, I'm not telling the diagnosis, but what are your differential diagnoses at least? Okay, let's go. So here you can think, yeah, patient is having burning chest pain. Pain is 10 out of 10. A lot of things can come. I will tell you in the further slides that what should be the differential diagnosis, that we should not miss ACS, acute MI. And it's not only every chest pain is acute MI. There are other life-threatening things that should be kept in the mind by emergency doctor. He reports binging on alcohol last night and had multiple episodes of non-bloody, non-bilious vomiting through the night. No shortness of breath, denies smoking, denies taking extra psychiatric medicine, no family history of cardiac disease, no swelling in leg or history of blood. So if there is no swelling of history, that means we are ruling out the pulmonary embolism. Okay, next. So the sample history was taken. Past medical history is depression and anxiety. Past surgical history was none. Allergies none. Medicines, he is taking paroxetine and clonazepam because he's a psychiatric patient. Social history, no tobacco, no drug, occasional alcohol binge. And family history, non-contributory. He has not given any family history. Next. So after doing the primary survey, small history and actions, the secondary survey was done, which is head to toe. So general, patient is alert, oriented, remains uncomfortable, still, head is normal, eyes are normal, neck is full range of motion, no jugular vein distension. So we can rule out here if there is no jugular extension, distension, rule out the pulmonary embolism, tension pneumothorax, and pneumothorax. But here we found that patient is having palpable crepitus bilaterally, just normal lungs, normal heart rate, normal, regular, no murmur, no rub, no gallop. Abdominal is also normal and skin is warm and dry now. So these should be the any chest pain, any shortness of breath coming to you. There are a lot of different diagnoses that should come in your mind, but important is we should always rule out acute coronary syndrome. So acute coronary syndrome is having STEMI, non-STEMI, and unstable angina. So we have to rule out by doing the EKGs and cardiac enzymes. Pneumonia can lead into the chest pain. If it's one side, it can be a unilateral chest pain, like in the left side or right side. Pulmonary embolism. What are the other differential diagnoses that should come in this patient? Anyone, please? I will appreciate. Am I missing anything else? So yeah. So we have covered in the chest pain. We have covered in the heart and the respiratory system, but we have missed. There is another important organ in the chest, which is called esophagus. So we have missed the esophagus. So you have to rule out the esophagus in any chest pain. In any chest pain coming to you, you have to rule out the esophagus. Esophagus can have a lot of diseases with the esophagus. Whether it's a rupture, it's a tear, it is a spasm. So a lot of things can happen to the esophagus. Next. So ECG was done, which shows there is no STEMI or NSTEMI. Next. Chest X-ray is done. Can anyone interpret what is in the chest X-ray? We have a lot of leaders here. Okay, I will tell you later. CT scan was done to this patient also. Oh, these are the labs that were done to this patient. Okay, so we have the basic labs, which shows almost normal. Okay. Next, I think Dr. Shashank has written a very important point in the after seeing the X-ray. He's saying the patient is in the X-ray looks like the pneumomediastinum. Very good. Okay. What about this? Yeah. What is in this CT scan? Shashank, again, you see that you have rightly pointed out that in the X-ray there is lungs are normal, heart is normal, but there is pneumomediastinum. That means there is air or leakage in the the material of the esophagus material is going into the mediastinum cavity, which is very, very life threatening. So usually we miss these things. So also the CT is showing the pneumothorax, pneumomediastinum, air in the mediastinum. Yeah. So so here we have now seen, we have seen that someone wrote that I'm not able. It's okay. So after X-rays, after EK, ruling out the ACS, then you see you're thinking about pneumomediastinum. That means there can be tear or rupture of the esophagus, and the patient was giving the history of binge alcohol and multiple episodes of the vomiting. Usually these kind of syndromes happen after very hard vomiting. or even self-created vomiting that can lead into the tear or the rupture of the esophagus, leads which can be diagnosed by severe chest pain. One second, severe chest pain, instability of the patient, and we diagnose it clinically. We should not wait for the CT scan. It can be diagnosed on the on the X-rays, on the history, on the severity. And then consultation is we take the consultation of different specialties, gastroenterology, gastrosurgeon, and also if you feel that because in the DD there was a ACS, you can rule out the ACS also. So the test virus and cardiac enzymes are negative, D-dimer is negative, ruling out the pulmonary embolism, ruling out the ACS, and alcohol is also negative, which rules out the overdosing of the alcohol. So now what do you think? What is this? But I told in the beginning that the we should not miss the critical actions in the emergency, even if we miss the diagnosis, but we should not miss the critical actions from the beginning. So next, so the diagnosis after seeing the CT scan, after taking the history, after the severity of the patient, this is Boerhaave syndrome. So it is a tear leading to the rupture of the esophagus, which takes all the directs all the content, most of the content or some content from the esophagus to the mediastinum, and there is a air leakage. That's why the patient was having crepitus in the neck region. So crepitus is abnormal, and it can be because of the rupture of the esophagus, rupture of the trachea, airway. So, and in both the cases, whether it is a tracheal rupture or it is a esophageal rupture, it's a life threatening. And here if you would have missed the neck, तो ये diagnose तक आप नहीं पहुंचते. हम critical action भी, lot of critical action could have missed. So that's why I was urging and I was requesting that the detailed examination, head to toe examination, which is very quick. It is emergency physician is having a different approach that I just presented in few slides back, should be on the same way always. And every patient should be taken in priority. It's not that you will a patient is having abdominal pain, epigastric pain, and you are thinking that patient may be having a gastritis, or patient is having an AG, but you miss the chest, you miss the EKG. So we should have a vast, broad approach with quick and concise approach. So these were the critical actions that were very important to note. Crepitus on the physical examination, we should not miss in this case. Consider esophageal tear in differential of chest pain in this patient, or any chest pain. I urge please also always have a DD as a esophagus in your differential diagnosis. Chest X-ray to evaluate lungs and mediastinum, and stat consultation for the required doctor or the specialty. Resuscitation with fluids, additional broad spectrum antibiotics. IV fluids, broad spectrum antibiotics are important in Boerhaave syndrome, and then we have to involve the CTVS surgeon. So small 1 or 2 slides about the Boerhaave syndrome. So key includes recognition of the etiology as an extremely deadly, because this disease is very deadly if we miss, and mostly we miss this. So patient can lead into the death. Cause of chest pain, especially in the setting of vomiting and very uncomfortable appearing patient, we should rule out the Boerhaave syndrome. Aggressive fluid resuscitation should begin early, and patient's vitals will deteriorate if you don't start the IV fluid, you don't give the antibiotics. Skin will can become more clammy if you don't perfuse. Tissue perfusion is very important, either by giving the oxygen, either by giving the IV fluids, and to stop to add the quick antibiotics. So the curveball of this of the patient is usually in these kind of patients, when you are talking to the senior cancer patient, to your senior, that patient, sir, we have a patient with psychiatric history and he is complaining chest pain, we usually ignore these kind of patients. अरे हाँ कोई बात नहीं, psychiatric issue हो गया, कोई बात नहीं, दवाई खिला दो, ये antipsychotic दे दो. We ignore unless if you have done the detailed, quick, concise head-to-toe examination, and you have found the crux, the red alerts in this patient, then you are confident to talk to your consultant. No sir, it looks like a Boerhaave syndrome, it's a life-threatening condition, and I must admit, and you should come and to see the patient. It's very, very important. Your emergency physician should be very confident, and the confidence comes only if you know how to approach a patient. If you don't ask the question, then we will ask the question. Yes, Vandana?
Yeah, I absolutely agree with you, Dr. Harmeet. So I would request all the participants to mention it is in the chat box, your questions. And thank you so much, Dr. Harmeet, for such a structured and practical walkthrough. The clarity around initial assessment, red flags, and decision making under pressure will be extremely useful for everyone here. So we will now move on into the question and answer session. I'll begin with a few questions that have come in from the audience, and then we will take more live questions as time permits. So
I
the
think we
first
have
one,
Dr. Shashank, Dr. Wasim, and other emergency physicians. You can please, can you on your, your cameras, and we can see each other, and also you can participate in the discussion also.
I would request Calden to give the access to all the participants.
Calden.
Calden, could you please give the
Yes,
access?
It's given. They can turn it on.
So meanwhile, they are turning on the camera and asking the question. Hi, Dr. Shashank. So Dr. Harmeet, there is a question that when a patient enters the ER and everything feels urgent, how do you decide what truly needs attention in the first 5 minutes?
So that's the there is a process which is called triaging. So triaging is important, and you should know how to triage, what to triage, when to triage, and then only you decide which kind of. I told you in the beginning that you must get a ऐसे patient आपके पास आते हैं जिनको कुछ भी नहीं होता है, but they have a lot of chaos के मर गया. It's your job that to try the patient and recognize his actual condition. Triaging.
Yeah, thanks. So Dr. Safir is writing in the chat box, good evening. I suggest to add cervical spine evaluation and initial assessment. C can include both circulation and C spine assessment.
I think there was a back examination was there. So back means spinal, spinal back is that I was meaning that only back.
Thanks for the clarification, Dr. Harmeet. The next one is, can you share an example where the initial ER approach, good or bad, completely changed the patient outcome?
Can you repeat the question?
Yeah. So can you just give an example where in the initial emergency room approach, good or bad, completely changed the patient outcome?
It's a very good question, and good or bad by the patient or by the doctor. I told you, in the starting I showed you the incidence slide that if we don't have a good approach, we can lead into a lot of incidents to the patient. For example, mortality can increase. You won't be able to recognize the criticality of the patient. You can miss the diagnosis. You can miss the critical actions. So these are the bads that can happen if you don't have you don't have the knowledge how to approach a patient, what to do on the patient when you are on the bedside. So this all needs training, and also practice on the patient every day. So whatever you learn, because I have seen a lot of emergency medicine, and people come and they focus only one symptom. The patient is having chest pain, they focus only chest pain. If the patient is having abdominal pain, they focus on the abdomen. They forget other parts of the body. So there we miss a lot of things. So good thing is that we should always have this approach, head-to-toe examination, primary survey, secondary survey, head-to-toe examination. And actually, I recommend if a patient is simple, do the examination to every patient. This won't take much time. This all, whatever we have discussed today, starting from the primary survey, triaging, primary survey, secondary survey, and all, it takes very less time, 10 minutes, 15 minutes if you are quick. Maybe in the starting it will take some time, it will take more time, but once you are you are experienced on that, it will take very less time, and your recognition power, your picking power of high alerts will be very refined.
Absolutely agree, Dr. Harmeet. So there's a message from Dr. Wasim. He's written that also in addition what was said, it is also important to keep patients in loop what we are doing and why we are doing, so that patient is also part of the process in his treatment, or his relatives, they feel more valued.
Thank you, Wasim. This is an important point also, as it was also mentioned by Dr. Bajaj also. Communication. So remember, I always teach my students 2 points, 2 lines. Communication with documentation and documentation with communication. Remember these 2 points. Whatever you communicate to the patient, to the doctor, please document it. And whatever you are documenting, you are writing about the patient or anything, consenting or anything, please communicate to the patient or to the concerned person. This is a very important point. Thank you, Wasim.
Yeah, I absolutely agree. The next one, Dr. Harmeet. In tier 2 or resource limited settings, how should clinicians adapt their emergency room approach without compromising patient safety?
So I think I was urging right from the beginning that first initial stages, you whatever the PPT, if you want, I will share with you, or I will can share you the paper. So keep this paper with you, okay? Keep it paper with you whenever you are checking the patient, and you can do there in first few days. In first few days you can do this, and after that you won't need any paper. So initial assessment right from the beginning, primary, secondary survey, doing very quickly, it will come with the practice only.
Yeah, absolutely agree. The next one is, how do you stay clinically calm and decisive when the family is anxious and the ER is overcrowded?
I think every emergency physician will has to be very calm. Emergency physician, because emergency is always chaos. It's a full of crowd. It's full of what I can't say the words. It's full of everything. So you can be abused by the crowd. You can be abused by the attendant patient, even harassed, और कुछ भी हो सकता है, आपको थप्पड़ भी खाने पड़ते हैं. But being a professional person, we should be very calm. ये experience के साथ आता है. It will come with experience, and try to because in the emergency room, in the emergency department, even very simple fever patient, you know that this is a simple fever and it's a green patient, it's not red, yellow, but the patient doesn't know. For the patient, he's red, because they don't have the knowledge. So it is our duty, being emergency physician, we should communicate to the patient, and that what actually attend the patient. Actually, in India, in UK, if we go to the UK, Wasim will agree with me, UK, US, there's a proper triaging system. There is a waiting time there. Red, yellow, green, there's a proper waiting system. Even in the emergency, outside emergency room, patient stays 3-4 hours, more than that also, okay? So people are aware, they are vigilant about that. They won't fight. Maybe sometimes they fight, but not like in India. But in India, this approach will come slowly. But who will start this? We are the people, emergency physicians, who have to start this slowly, by keeping ourselves calm, by keeping your team calm, by not reacting unnecessary. And believe me, if you have a proper communication, proper closed loop communication with the patient will never agitate, will abuse you. So that most of the things come when there's a breach of the communication.
Yeah, exactly. The next one is, Dr. Harmeet, as you have worked with many young physicians, so what are the most common mistakes young doctors make while approaching their first emergency room patients?
So I have seen that shortcuts. So detailed examination nahi karna, shortcuts, lazy, this is the only shortcuts. So there is no shortcut, because emergency approach is itself a shortcut. So if you see the medicine, there is a huge, big history, but our approach is very concise, very accurate, very short. 10-15 मिनट में आप पूरा सब कुछ पेशेंट का सब कुछ देख सकते हो. तो मेरा ये रिकमेंडेशन है, प्लीज उसको मिस मत करो. ये बहुत सारी मिस्टेक होती है. और दूसरा होता है कि फर्स्ट डे या फर्स्ट इमरजेंसी रूम को आता है, दे आर ऑलवेज एंशियस टुवर्ड्स टू देयर सीनियर्स, क्योंकि फर्स्ट टाइम दे आर फेसिंग द क्रिटिकल पेशेंट, दे हैव नेवर सीन बिफोर द क्रिटिकल पेशेंट. सो maybe they are anxious, but with time they will be much confident. Then they will, मैंने कई बार अपने स्टूडेंट्स से देखा कि पहली बार जब आते थे, they were भागते रहते थे, पेशेंट को देखना नहीं है, इधर जाना. शशांक को पता है कि पेशेंट भाग जाते हैं, पेशेंट मतलब जूनियर आपके भाग जाते हैं पेशेंट को देख के. But with time, within 3 months, 4 months, if the person is very serious, learning things, is very dedicated, 1 महीने के अंदर he will be very much confident, and he will be happy, he will enjoy attending the patient. Actually, once you start enjoying your work, attending the patient, you will like it and you will flourish.
Absolutely agree, Dr. Harmeet. And the next one is, when diagnostic certainty is not possible immediately, how do you protect both the patient and the clinician?
So I told in the beginning and in my whole this talk, in emergency medicine, we being a faculty, being an examiner, everyone will agree. Wasim is there, Shashank is there, other emergency physicians are there. We don't bother about the diagnosis. We bother about the critical actions in the emergency department. So we should not miss the critical actions. And if you even don't know the diagnosis, just keep going the detailed examination with that approach that we have shown now, and you will very minimally you will miss anything. एंड यू विल एक्ट ऑन द, फॉर एग्जाम्पल पेशेंट को चेस्ट पेन हो रहा है, आपने उसको पेन किलर देना है, आपको पता है कि ये एसीएस हो सकता है, आपने उसका ईसीजी करा लिया, कार्डियक एंजाइम करा लिया, आपने एक क्रिटिकल एक्शन रूल आउट कर लिया इस पेशेंट में। इन दिस पेशेंट देयर वाज अ क्रेपिटस इन द नेक, दैट वाज द फर्स्ट थिंग दैट जो हमें जो पकड़ में आता है, हमें वहीं पर पता चलना था कि हाँ जी ये बोरेवस है या फिर ये ट्रैकियल रप्चर है, कुछ है, तो वहीं से हम उसकी हमारी डायरेक्शन उस तरफ चली जाती है। तो दिस इज वेरी इंपॉर्टेंट।
And I would request participants to keep on posting the question and looking into the paucity of time, if you could quickly pose the question while Dr. Harmeet is answering the next one. What advice would you give to young doctors or nurses who feel overwhelmed during their early year postings?
I think this is very important. I think there are a lot of the young people, fresh people coming on this platform today, and they are asking the same question again and again. So for I think my advice will be whenever you are coming to the to the new department, even in the emergency department, and you are new, your first day, I will tell you the 3 fundas of success in your life. First is follow your senior. आप अपने सीनियर को फॉलो करो, उनसे सीखो, लर्न फ्रॉम योर सीनियर्स and get the benchmark knowledge, sit with them and discuss with them. That is second level. And then gain such knowledge, then you can go ahead of your seniors also in process of knowledge, skills and all. So ये 3 steps होते हैं. अब ये नहीं कि आप आए आज और आप you want to be ahead of your senior, because किसी न किसी एंगल से your senior must know more than you, because he has given his or her time, years of time in the emergency, and everything is not about the book protocol. So experience also matters. There are a lot of things which are not even mentioned in the book, but by gaining the experience, you know that you recognize these things.
Yeah, I agree. So I would request participants to keep on posting the question, and could you please turn on your camera so that we can quickly capture
I would like to. The scene is there, Shrink. They should also answer.
I would request all the participants to turn on the camera so that we can capture the moments. And as we close today's session, we come back to where we started. An emergency room door opening, a patient arriving, and a clinician standing at the center of that moment. Today's discussion reminds us that approaching a patient in the ER is not just a clinical act. It is leadership in action. Approaching a patient in the ER is not just about protocols. It's about judgment, empathy, teamwork, and calm under pressure. On behalf of all of us, my sincere thanks to Dr. Shuchin Bajaj and Dr. Harmeet Singh for their enriching perspective, practical wisdom, and real-world learning. A special note to the appreciation to the academics and research team, particularly Mr. Carolyn, for the excellent coordination and execution of this session. And thank you to all our audience for the work you do every day, often unseen, but always critical. We hope this session adds value to your daily practice and strengthens your confidence in emergency settings. Stay safe, stay steady, and keep saving lives, one golden hour at a time. Thank you, and a very great day ahead. Thank you so much, everyone. Karen, I hope you have captured the this moment. I can see all the cameras turn on now, and I would request, if you still have any question, you can drop in a chat box, or else we will call it a day.
Thank you.
Thank you. Thank you, everyone. Stay connected. Bye.